Hi, I'm Lakshmi Yatham. I'm the co-chair of ACUMEN, an e-learning program for clinicians developed by the World Federation of Societies for Biological Psychiatry. The focus of today's module is long-term course of cognitive functioning in patients with schizophrenia. We're going to try and cover 3 or 4 different things in today's module. So things such as, do young people at risk for schizophrenia have cognitive and perceptual impairment? And if they do, what does the research tell us in terms of some of the strategies that one might employ to reduce those cognitive deficits? Now, we as clinicians know that patients with schizophrenia have cognitive impairments. The question is, what happens to that cognitive impairment over a period of time? In other words, what's the longitudinal course of cognitive functioning in patients with schizophrenia? And what do we as clinicians can do to address or minimize the cognitive impairment that we see in people with schizophrenia? So to talk to us about all those issues, we have Dr. Richard Keefe, who is a professor of psychiatry at Duke University. And as we all know, he's an internationally renowned expert on cognitive functioning in schizophrenia. Rich, it's so nice to have you in this program.
Great to be here, Lakshmi. Yeah,
wonderful.
Thank you.
So, we as clinicians, we are aware that people with schizophrenia have cognitive impairment. The question that runs through clinicians' minds often is, does this mean that every patient with schizophrenia has cognitive problems?
Yeah, no, it's a great question, and particularly important for clinicians as they consider whether their patients have a cognitive issue. So most patients with schizophrenia do. And so if you define a cognitive impairment as performing very poorly on cognitive tests compared to the average healthy person, then it's about 75% of patients with schizophrenia. However, we know from some of our research that if you look at the people who are considered to be healthy in terms of cognition who have schizophrenia, they're often people who maybe were in medical school or were at a top educational institution before they had their psychotic break, and they've declined substantially. In fact, our work suggests that about 98% of patients with schizophrenia had some decline compared to what they would have been if they had never developed the illness.
That's a very nice distinction. So it sounds like there is a clear decline relative to their baseline cognitive functioning for pretty much most patients with schizophrenia. But when you compare them with an average person in general population, that may not show up, right?
That's exactly right. And in fact, some of the work of Ken Kendler and others has shown that having a decline relative to the average member of your family, having cognitive performance that's much less than your average member of your family, is actually a risk factor for getting schizophrenia later in life.
Okay, that's very interesting. So I guess the other question that comes up is, of course, in patients with schizophrenia, we treat their psychotic and other symptoms of schizophrenia with various psychotropic medications. And the question is, when we talk about cognitive impairment, is the impairment present even when their psychotic symptoms remit?
Yeah, very important, and it certainly is. And in fact, antipsychotic medications have very little impact on cognitive impairment, and a state of relative remission in schizophrenia also has very little impact. So most of the cognitive research that has been done on patients who are not flagrantly psychotic. In fact, the severity of their symptoms, their psychosis, hallucinations, and delusions, is not correlated with the severity of the cognitive impairment at all. And that's often very surprising to hear, but I'd say over 100 studies have demonstrated that, so we're very convinced that it's true.
That is surprising, isn't it? Because you would expect some of these psychotic symptoms to affect attention, concentration, which in turn might affect other domains of cognitive functioning, yet it sounds like from what you're saying, in terms of magnitude of impairment, it seems to be fairly similar whether they're symptomatic or not.
It does, and there's a number of somewhat complicated reasons for that. But one thing that's important to note is that the patient who's in the emergency room, who is screaming at the voices and can't sit still and completely agitated, those patients, of course, are not in any kind of cognitive research studies, and you would expect that their cognitive impairment is very, very severe. But not counting those folks, if you look overall, that the patients who have cognitive impairment, the worst cognitive impairment, are often the ones that have negative symptoms, but they don't necessarily have a lot of psychotic symptoms in addition.
Okay, that's interesting. So that brings us to another critical question, and that is, what causes cognitive problems in people with schizophrenia?
Yeah. So we don't really know. It's very clearly a core part of the illness. And some theories, including some of the things that we've worked on, focus on the idea that cognition itself may be one of the core aspects of the illness that then later in life causes the psychotic symptoms that we see. So if you want to look at what causes cognitive impairment in schizophrenia, there are a lot of factors, certainly brain function, genetics as well. We now know that there are over 100 genes that put someone at risk for schizophrenia. Some of those genes actually put people at risk for cognitive impairment, even if the person doesn't have schizophrenia. So more and more the research suggests that the cognitive impairment is a core part of the illness. So whatever causes schizophrenia is causing cognitive impairment too.
That's very interesting. So there's almost, you got genes that predispose you to cognitive impairment, and then there are other genes that increase the risk of both cognitive impairment and schizophrenia. Is that?
That's right.
Okay.
Yeah.
Okay. So, so the next question is, when does this impairment begin? Because I mean, if there are genes that are predisposing people to have both cognitive impairment and schizophrenia, is this something that you actually see before a person develops schizophrenia?
You do, and you actually see it in the childhood of people who eventually develop schizophrenia. So if you had to trace the cognitive impairment throughout the course of somebody's life prior to the onset of psychosis, you'd see that in early childhood, age 3, 5, 7, you see a slight decrement. Not anything you would notice. So for instance, you couldn't go into the early school years and say, oh, this child is going to develop schizophrenia because they're doing poorly in cognitive tests. It's much more subtle than that. But when you look on average, the people who develop schizophrenia are doing worse on cognitive tests from age 3 on. And then they also, and I think this is the most important thing, is that they decline over time. So of course, one of the most important things we do as humans, as children, is we learn, and we learn how to do things, and we learn how to learn. And in children who are going to develop schizophrenia, they learn, but not at the same rate of the other children. And so after 13, 15 years of being behind and then falling behind, they enter the difficulties of adolescence with a cognitive impairment that has probably led to some social impairment. And that may be one of the crucial aspects of what causes schizophrenia to begin with.
That's interesting. So then if we think about the severity of cognitive impairment, how bad is that at the onset of the psychosis?
Yeah, at the onset of psychosis, it is severe. So on average, the average person with first episode psychosis is performing about 1.5 to 2 standard deviations below the general population. So to put that on other terms, that's about the lowest 5% of the population. And so if you were talking about IQ, which is a little bit different from cognitive performance the way we're talking about it, but if you talked about IQ, that level of severity would be at the range of pervasive developmental disorder or what used to be known as mental retardation. So very severe as soon as the psychosis develops itself, and that doesn't change much over time.
Right. So imagine if it is that severe, 1.5 to 2 standard deviations below what's expected. imagine that would have significant impact on functioning.
Yes, it does. And I think that's probably the most important aspect of cognition in schizophrenia, and probably one of the things that has compelled a lot of researchers to focus on this area, is that the ability to have social relationships, to work, and to live independently, some of the things that we consider to be the most important aspects of our life, right? What gives us a sense of being and quality of life. Those aspects of the illness are driven by cognitive impairment more than they are by symptoms.
Interesting. So, of course, when we diagnose someone with schizophrenia, we as clinicians start thinking about using antipsychotics to address the symptoms. And some of them, or many of them, do treat psychotic symptoms. The question is, what about their effects on cognition?
Right. So there's been a lot of work in this area over the past 20 to 30 years, and there was a time when we initially thought that the novel antipsychotics, as they came out, like olanzapine and risperidone, there was some evidence that those drugs were better than the older drugs for improving cognition. The more we did the research, though, the more that hope, unfortunately, kind of fell apart, and it looks as though a lot of that was driven by some of the dosing effects of the older medications. The older medications were dosed in a range that caused things like sedation, extrapyramidal symptoms that the newer drugs weren't causing. However, it does look as though when a patient has a first episode of psychosis and they are started on an antipsychotic, it does improve cognition a little bit, which is probably related to some of those patients who are very psychotic and are doing very poorly on tests because they just can't pay attention. But other than those patients, the rest of the folks don't seem to really improve very much in their cognitive performance, even though they can have dramatic changes in their symptoms.
So it sounds like the hope that came with this advent of these second-generation antipsychotics in terms of their beneficial effects on cognition hasn't really panned out.
No, unfortunately not. And it was very discouraging, because I think that there was a time when we thought that these new drugs were really going to be a panacea for lifting people with schizophrenia up to be able to have cognitive improvement, but to function better. And as you know, the general functioning of the average person with schizophrenia hasn't changed, and my colleague Phil Harvey has done a lot of great work showing that this hasn't changed for 100 years.
Interesting. So you talked about people with schizophrenia having about 1.5 to 2 standard deviations in terms of their cognitive function below what might be expected. So the question, and that seems to be present, as you said, almost at the disease onset, more or less, right?
Yeah, that's right.
So what happens to that cognitive impairment over a period of time? Because as we know, schizophrenia starts at a pretty younger age.
Right.
And people have, 60, 70, 80 years to live. So what happens to that cognitive functioning?
Well, it doesn't change very much. And so the level of cognitive impairment that a patient has at the first episode of psychosis, if you look at chronic patients, right, who are 30, 40 years older, it appears as though they may have more cognitive impairment than patients who are younger. However, those research studies are done in such a way that the young people are often people who have a lot of social interactions. They may be showing up to a university clinic, whereas the research in older patients is done at state hospitals and places where often the patients who are having the most difficulty are being treated. So it's not a real fair comparison. The longitudinal studies that have followed patients over a long period of time, there's very few of them. They suggest that there is a small decrement in cognitive function in those patients over time, but certainly not the type of decrement that you would see in a dementing condition like Alzheimer's disease.
Okay. So maybe we'll come back in a little while to talk about what might clinicians do to address the cognitive impairment that we see in people with schizophrenia. Yeah. But I just want us to go back and talk about younger people, because you started out by saying that younger people also have cognitive impairments, and that sort of progresses at least until the disease onset. So the question is, in terms of the nature of impairments, cognitive impairments, in younger people that are at a high risk for schizophrenia, is that different, the nature of impairments, compared to those that have schizophrenia already developed?
Not very different.
Okay.
And we've done some work, a number of groups have done some work looking at young people who are at risk for psychosis by virtue of their symptoms, not even their cognition, but just look at their symptoms. And some of these symptoms, like having perceptual abnormalities, odd ideas, maybe odd speech, these high-risk criteria, if you do research on the young people who have those types of symptoms, you do find that they're doing cognitively worse than their peers, same age, who don't have those symptoms. However, a lot of the cognitive problems that they have are more general, such as memory, processing speed, the types of things that are found in schizophrenia. There are also some other interesting findings suggesting that their ability to generate affect and generate speech is often impaired as well. And what's interesting about that is that those young people who have those types of problems probably are going to have social difficulties as well, and that may explain some of the social isolation that we see in a young person. And it could be, and there's not a whole lot of evidence, it's fairly speculative, but it certainly could be that a young person who has social isolation, fairly modest cognitive impairment, and can't express themselves very well, and maybe can't understand how other people feel, is going to become further socially isolated. And that may be the way that they start to comfort themselves and be rewarded by their own internal mind machinations, if you will. And that becomes a more comforting world for them than the interaction outside, which they really are failing to understand.
Interesting. So we as clinicians then identify people at risk for psychosis based on some clinical kinds of symptoms, right? So, and you're saying that these people do have some of these cognitive impairments. So the question is, are there strategies to address those cognitive impairments in younger people? And if we did, would that actually change the risk for psychosis onset?
Yeah, that's one of the holy grails of psychiatry, really, right? Because can we identify people who are at risk for psychosis and then prevent the psychosis altogether? So there's nothing that is approved by FDA, of course, any pharmacologic interventions. There have been some studies on cognitive remediation strategies, though. So that process I talked about being able to understand how other people feel, being able to listen better to other people, that type of cognitive perceptual process can be improved by cognitive remediation strategies. And there have been a number of studies showing that people at high risk for psychosis do benefit from those cognitive remediation strategies. Now, whether that will lead them to not develop psychosis later has not been demonstrated yet convincingly. There have been some small studies suggesting it, and I think it's an area of exploration that the research field really needs to get behind. But right now it's speculative.
Okay. So that sort of brings me to another question, and we may not have the studies to answer that, because I'm just wondering, as you were speaking about this, because you talked about these cognitive problems getting progressively worse, more or less, in younger people until the onset of psychosis, right?
Right.
And you said that if we use strategies such as cognitive remediation, it might improve some of the cognitive functioning, but we don't know if that actually changes the risk for development of psychosis.
Yes.
But I guess my question is, if the cognitive remediation is improving cognitive functioning, would the magnitude of impairment in those people then at the onset of psychosis, would that be different? Do we know the answer to that? Or
I'm sorry, would the what?
Would the magnitude of cognitive impairment in those that have had cognitive remediation and then went on to develop psychosis.
Yeah.
Would their cognitive impairment be maybe perhaps one standard deviation or half rather than 1.5 or 2? Do we know the answer? Or?
No, we don't. It's a great question. We don't know the answer to that. But, we do know that cognitive remediation makes things a little bit better in those folks. And we also know, pretty convincingly, a number of studies have demonstrated this now, so a young person has these symptoms, high-risk symptoms. Adolescents have a very tumultuous internal world and external world. It turns out that some of those people who are at high risk, and when you follow them up a year later, they actually don't have the symptoms at all anymore. So they have remitted from that state. And those people, those young people, they have their cognitive impairment remits as well, and their perceptual impairment remits as well. So these are longitudinal studies. But it certainly suggests that if you can improve cognition and improve perception in those young people, you may be able to sort of facilitate that remission early on, and they won't be folks who develop psychosis later. Furthermore, just one other aspect of that is that often these symptoms are associated with difficulty and suffering. And so a program that can improve those symptoms in and of itself would be effective, right? Because you're just helping a young person with something that really they're struggling with. Whether or not it predicts psychosis later on, in and of itself, it's very good.
Yeah, it's fascinating because I suppose that's where we would have the highest impact, wouldn't we? I mean, if we are able to come up with strategies that would address the cognitive impairment and somehow reduce the risk of developing psychosis, then we would have addressed a significant part of the psychiatric issues, I would think.
Tremendous. Yeah, I think that may be one of the most important aspects of psychiatry research today, is being able to identify which young people are at risk and being able to give them, a safe treatment. It can't be something like an antipsychotic because there's too many side effects, and you can't give a drug that's very powerful and has side effects if you don't know that the person's ever going to really get a full-blown illness. But very safe, mild treatments like cognitive remediation or other compounds, drugs that might not be very strong and have side effects, those would be very valuable because then you could prevent this horrible thing that we see. Once somebody has psychosis, they really have a very difficult time.
Great, thank you. So I wanted to go back to one of the things that we were talking about earlier on, and that is the second generation antipsychotics, the hope and the expectation, and as you mentioned, it really didn't pan out as we had hoped. I guess when we talk about the second generation antipsychotics, there's a whole bunch of them that are out there, right?
Yes.
We often lump them together, but we know that there are differences in terms of their receptor profile, pharmacology, and all that stuff. So the question is, would that statement apply to all second generation antipsychotics? Are there some of the ones that, because of their pharmacology, might they offer some hope in terms of addressing cognitive aspects in schizophrenia?
Yeah, so there have been a couple of recent studies, and there's been a study with lurasidone. There have been some other studies showing some mild cognitive changes. These changes, though, are very small. And so when you look at the magnitude of the cognitive impairment, 2 standard deviations, these changes with antipsychotics might improve patients, like I'd say 1/10 of that. And so while that impact may be statistically significant, it's not the kind of change that we need to be able to really have a powerful impact on a patient's quality of life and ability to function.
Okay. You talked about cognitive remediation earlier on, especially when we were talking about modifying some of the cognitive challenges that we see in younger people. What about research on cognitive remediation in people that have established schizophrenia?
Yeah.
That 1.5, 2 standard deviation, would that be amenable to change with something like cognitive remediation?
Yeah, it's a great question. It appears as though it does. So there have been a lot of studies. Most of them have been academic in origin, but a number of them have demonstrated that cognitive remediation improves. I'd say about 0.4 standard deviations seems to be the average. So that's not small. It's not large. It's kind of in between, but it does seem to be something that could be clinically meaningful. Some of the larger studies, though, that tried to address this in a way that would provide regulatory acceptance of that intervention have not been positive. So right now, there's a current tension between very small academic site studies that have been positive and then the larger ones that are required for regulatory acceptance of the intervention have been negative. So it's not really clear what the path forward for schizophrenia is going to be. But I also think that it's very safe, right? And so doing cognitive remediation, if it does work, is a great thing for clinicians to do to try to help their patients.
So that's interesting. I'm just wondering whether you have any thoughts on why the discrepancy might be in terms of the benefits, right?
Yeah.
The academic centers versus large clinical trials. Could
Yeah.
it be the variability? In other words, some of the non-academic centers in terms of how they administer the program or rating. I'm just wondering what might be some of the reasons.
Well, it's a huge question. I mean, I think we could have, you could have a couple of different interviews based solely on that question alone. I think it's the process, just like with the drug development program, right? Early on, it appears sometimes with open label studies or with single site studies, a new drug might look like it's very effective. And then you take it to the regulatory process in a large phase 2 or phase 3 program, and it doesn't work. And so the question is, which is wrong, right? Was it the early data maybe done with a methodology that included people who believed in the treatment and wanted the treatment to work? Or is it that when you take that treatment that indeed does work and you go to these large studies with 50 different sites, you introduce noise into that system, and so then therefore the signal itself is no longer detectable. And so we don't really know. We don't really know with cognitive remediation. I think if it's an FDA drug, obviously you have to go through that system because the drug may have deleterious side effects that are dangerous for the patient. With a cognitive remediation strategy, I don't think it matters as much because they're available commercially to people to purchase. I guess part of the issue is a payer issue, right? No one will reimburse that, and the patient will have to buy it themselves or get somebody to buy it for them. But I think if it's possible, it is a good strategy for an individual patient.
Okay. So we also talked about cognition having significant impact on functioning. Mm-hmm. I know in bipolar field, which is my area, some of the researchers are using functional remediation strategies, which of course include a huge component of the cognitive remediation, right, but also add a few other functional remediation strategies as well. So I'm just wondering, given substantial impairment in functioning in people with schizophrenia, is that something that one should be thinking about as well?
Yes, and so there has been some work, a number of people, Phil Harvey, who I mentioned before, Susan McGurk, others, they have combined cognitive remediation strategies with things like work skills programs. And they find that the two in combination with one another actually have an effect of not only improving cognition, but then taking those cognitive gains and then being able to improve how the patient's living outside in the community as well. And I think that's a very viable and important strategy, research strategy, but also for an individual patient, an individual clinic.
Wonderful. We obviously covered lots of things in this module, and I'm just wondering whether you might be able to come up with 3 key messages for our clinicians, key take-home messages.
Yeah, I do. Thank you. So I think, first of all, psychiatrists aren't really trained in neuropsychology and cognition as much, so they don't think about that first. They think about the psychotic symptoms, the hallucinations, and the delusions when they have somebody for schizophrenia. So I would urge clinicians to look for cognitive impairment because that is often the thing that bothers patients the most, bothers family members the most, and it inhibits them from being able to enjoy the aspects of life that we really find valuable. So I think the first message would be to psychiatrists to please look for cognitive impairment in general. Secondly, well, once you see cognitive impairment in patients with schizophrenia, what do you do about it? And while the choice of the antipsychotic medication might not be as important, things like dosing, anticholinergic load, so there's been some great work suggesting that the higher the anticholinergic load, whether through an adjunctive medication or the load itself, that can have an impact on learning, which can be associated with other cognitive problems. Extrapyramidal symptoms, sleep can cause cognitive problems. So choosing what type of medication strategy, not just about symptoms, but about cognition, is also very important. And then third, I think with regard to those who are at high risk, so for some of the folks who are tuning into this and treating young people, to be aware of those high-risk symptoms, because often those young people will have depression, anxiety, but if you inquire about whether they have some of these high-risk criteria, and so the DSM actually has a supplemental diagnosis of attenuated psychosis syndrome. Those patients who meet those criteria may benefit from some of these strategies that we've talked about, and to keep an eye on whether or not they may be at risk for psychosis. So some of the interventions that clinicians can do early on may not only help them now, but may help them for the rest of their lives.
Wonderful. Thank you so much for taking the time to talk to us this
Great,
morning.
yeah, my pleasure, Lakshmi. Thank you.